President Sir Roy. It is my privilege and a great pleasure for me to introduce to you Paul Tersasaki as an awardee of this year's Medawar Prize. Tersasaki is a household word in the field of transplantation. Perhaps more than anyone else, Paul Tersasaki is recognized and respected both in the laboratories and in the clinical transplant units. Of course, that is no coincidence. Paul's work has been of fundamental importance, both for basic and clinical transplantation science. Remarkably, although he did not formally train in medicine, Paul holds an appointment as a full professor of surgery at UCLA. Having had the privilege of working with Paul for 10 years, I know that many patients have approached him and requested to have the transplant operation performed by him personally. Wisely, and probably luckily for the patients, he has declined all such requests. His main area of interest, of course, is the field of histocompatibility, where he has made enormous contributions. I dare say that without his innovative work, HLA typing would not have progressed to its present state. He has organized the milestone 1970 and 1980 International Histocompatibility Workshops, and those who have been around during the times before an international HLA nomenclature was established will remember the many TE specificities, the HLA specificities discovered in Paul's laboratory. But Paul Tersaki's contributions reach far beyond the field of histocompatibility. The exceptionally wide range of his work is perhaps best exemplified by the fact that something as remote from histocompatibility as the cold storage solution for kidney preservation also was pioneered in Paul's laboratory. He is the father of modern computer-age transplant data analysis. A statement he has often made is, "The computer keeps you honest." His uncompromising honesty in reporting results as they are has not always made life easy for him. Those who attended the Transplant Congress in The Hague in 1970 may remember his historic presentation showing the absence of an HLA matching effect in his data collection, a report that resulted in the loss of grant support from the NIH. Later, based on improved typing techniques, he of course showed the first statistically convincing evidence of an association of HLA matching with graft outcome. Throughout the years, Paul Tersasaki has time and again produced surprising and very stimulating results. A notable recent example was his startling report last year on the superior survival rate of unrelated live donor transplants. Paul has remained a humble and considerate person. Outside his working environment, he's not very outgoing. That is not to say, though, that he doesn't share with us some of the weaknesses that many of us have. Could I have my slide? I'm sorry, you have to go one back. On a rare occasion, one can get a glimpse of that. This may have been his first cigar. It also may have been his last. I believe he did not enjoy it very much, and those of us who know him very well know, of course, that his preference really is candies. Now, as to say, behind every great man stands a great woman, and that is particularly true for Hisako, who I'm very happy to see is here with us today. Paul Tersasaki was a postdoctoral fellow in Sir Peter Medawar's laboratory. I know he will value the Medawar Prize above all other honors he has received. The Transplantation Society is the most important professional society to him. This society is where he feels he belongs. We, as the Transplantation Society, can be proud that Paul Tersasaki is a recipient of the 1996 Medawar Prize. Paul.
Thank you, Professor Pels, for that tribute to I-Tersasaki, who now has the floor.
Lady Medawar, Sir Roy, Dr. McVeigh, ladies and gentlemen, I'm multiply honored by the Medawar Prize. First, I'm especially honored since I myself was a student of Sir Peter Medawar almost 40 years ago. Secondly, I'm honored of receiving the prize from Lady Medawar, who helped our family with 2 small children first establish ourselves in London. And thirdly, I'm honored by the flattering introduction from my associate of 10 years, Dr. Gerardo Pels. Thank you, Gary. May I have the first slide? The first slide. Professor Peter Medawar was chairman of the Department of Zoology at the University College London and had not yet received his knighthood or Nobel Prize. For in the long run, others will do what they have been unable to do themselves. This is a humbling insight into what we do, told to us by our leader. But for us lesser mortals, the game of trying to do it first is where our fun and excitement is. In looking back at my own work, I find that it is best characterized by the Spanish author Cervantes. Like Don Quixote de la Mancha, with his delusions of grandeur, I stumble around most of the time attacking windmills. It gives me a great deal of pleasure today to come to España to recount stories of my adventures, or at least the best parts. Upon leaving Medawar's lab, I was faced with 2 possible courses of action: to work on the PRA test or panel reactive antibody, and those patients that did not have antibodies had a higher graft survival than those patients who had antibodies. The PRA test has proven to be useful in detecting sensitization to pregnancies, transfusions, and rejections of prior transplants. It's interesting that even today, the only way in which we can tell that a patient is immunized or not is the humoral antibody test and not a cellular immunity test. The first HLA specificities were identified by the leukoagglutination test, as we just heard by Jean Dosset, by Van Root, Payne, and Bodmer. However, it was only until after the microcytotoxicity test was adopted as an international standard that the rapid identification of new HLA types followed over the next 16 years. By 1987, 118 HLA types that we use today for kidney transplantation matching was established. This rapid progress was due to the exchange of small quantities of valuable antisera, which was made possible by the microtest. After 1990, an even more explosive work on the identification of types occurred with the emergence of the revolutionary new DNA technology, increasing the types over 300, which we will speak of later. The microtest also made it possible to ship tiny quantities of cells from Los Angeles to many laboratories throughout the world to standardize tissue typing. Every month since 1974, 4 people were bled in Los Angeles, and we shipped these cells to 100 laboratories, up to recently 300 laboratories every month. And an additional 100 laboratories receive DNA samples for standardization. But because of this standardized typing, a kidney donor typed in one country can be matched with a recipient in another country. The microtest permitted mass typings of as many as 14 million individuals. Recently, 4 million volunteer bone marrow donors were typed by the microtest worldwide. Essentially, all transplant donors and recipients over the past 30 years have been tested by the microcytotoxicity test. It would not have been possible to bleed pregnant women who are the primary source of antibodies for so much antisera if microtest methods were not used. So in summary, the humoral approach led to the microcytotoxicity test, which then allowed us to do cross-matching easily and PR tests with large numbers of random donors. And most importantly, it has helped us to define the all-important HLA types. As the HLA types became established, I was most anxious to use this new sword to match kidney transplant donors and recipients. Dr. Singal in our laboratory produced the first proof that kidneys from sibling donors that were matched had a high graft survival compared to transplants from mismatched sibling donors. This finding has been confirmed over thousands of subsequent transplants and remains today the single most convincing evidence that HLA is relevant to kidney transplantation. However, our attempts to extend these results to cadaver donor transplants was agonizingly difficult and consumed most of our efforts for the next 25 years. This is the actual slide that I showed at the meeting of this society in The Hague in 1970. Dr. Mickey is shown here, did the complicated statistical analysis, but as you can see, my mind was operating at a lower, simpler level, and I had appropriated Lego blocks from my children. On this axis is the clinical rank, so A being the very best outcome of transplant, and on this axis is the matching, so A is the best match. And one of the things you see is that the best matched transplants, there are very few of them, and we really couldn't say much about them. But the difficulty that we had was in the poor mismatches. This is the worst mismatch. We had failures, but these patients were the difficult patients, where the surgeons insisted that the patients were doing extremely well, and we kept saying that the patient is mismatched. We worried a lot about how our typing had been done, whether we were making mistakes, and so on. But today, a quarter of a century later, we could ask, with refinements in HLA typing, how would the results look today if we were to plot it in exactly the same way? And this is from the UNOS Kidney Transplant Registry. Dr. Cheka is shown here, who is in charge of the UNOS registry and has been the source of invaluable data. The clinical ranks at 1 year is shown here. A is the patients with serum creatinines under 2, and these are different serum creatinines. F is the worst transplants. And on this axis, in the same way, is the 0 mismatch, the best match, the 1 and 2 mismatch, 5 and 6 is the worst mismatch. And you see that if we compare these two figures, they're quite alike. Actually, we still do not have very many 0 mismatch transplants, the best mismatches. And our biggest problem is here, where there are mismatched patients who are doing well. Now you might say that this does not look like the standard curves that we have been looking at. And if we look at the conventional way of plotting exactly the same data here, you see that the 0 mismatches have the highest graft survival, the 5 and 6 mismatches have the lowest graft survival. This difference here is the proof that HLA matching is working. But this difference from here to here is a proof that mismatched transplants do well. And one of the things that this type of survival curve does not emphasize is this large number, which is shown here. A large number of mismatched cases that are functioning well. And also it does not point out that this number is actually rather small in comparison to the others. But before you arrive to any conclusion about matching, it is critical to notice that we are talking now about 1 year graft survival. If we look past the 1 year. This is actually the only data that we had in 1970, the 1 year data. But if we look past the first year, we see an entirely different picture. Dr. Opal's is shown here because this data, independently gathered on a different set of patients, produced the same results. The data shown here is from the UNOS transplant registry. At 1 year, the difference between the matches is not very large, as we just saw. But if we observe the graphs, there's a marked difference in the rate at which the graph is lost, which progressively increases with more mismatches. Thus, by 10 years, the 0 mismatch patients have a 58% graft survival, whereas the 6 mismatched patients have a 36% graft survival, and at 20 years, this difference increases. Clearly, HLA matching is very important to the long-term success of transplants. If you were the patient, you would obviously pick the 0 mismatch donor. Moreover, HLA continues to be the most important predictive factor to use in allocating cadaver donor kidneys. But I would like to return again to the unsolved problem of matching, which is evident in the 3-year data, as shown in this slide. This is 3-year clinical rank, the best transplants and the worst, and then the best match. And you can see that at 3 years, the figure looks quite similar to the 1 year data. Now, the reason why we do not have very many 0 mismatch transplants is that the number of HLA specificities is very large, and the patient pool is too small so that we can't really get enough patients that are well matched. So the obvious solution is to increase the pool of recipients and share the kidneys more widely. Jan van Rooij, 30 years ago, proposed the formation of a Euro transplant sharing group. 30 years later, through no fault of his own, we have a very fragmented, nationalistic kidney sharing system, divided by many political boundaries. If all the dialysis patients could be put into a single international pool, Dr. Gertsen in our laboratory has computed 5 years ago that a recipient pool of 50,000 patients, as much as 36% of the patients could receive a 0 ABDR mismatch transplant, and you can see this changes this picture dramatically. And this can be obtained simply by breaking down the international borders with an agreement. In 1969, Dr. Jeffrey Collins developed a cold storage solution for shipping kidneys when he worked in our laboratory. Today, with this solution and modifications by Dr. Belzer, cold ischemia time up to 60 hours produces results that are similar to short-term storage. And this has been published in our latest Clinical Transplants 1995 book. Note that the 60-hour data is based on 590 transplants. So contrary to the common opinion, cold ischemia time is no longer a major risk factor, and international sharing has become quite feasible. Returning to the matching problem, it has been suggested that the new DNA typing is the answer to our current predicament. With DNA typing, many more specificities in A, B, and DR loci can be identified. But it should be obvious that the more antigens we have to match, there will be even less match transplant. Subdividing these match transplants by DNA typing results in very few patients that are really 0 mismatch. Dr. Cook yesterday showed data that only 15% of these would be truly mismatch, no mismatch by DNA typing. So you see that the main problem of HLA matching is not here, but is here. And one of the things that we have been trying to do is to see if we could move these patients who we consider mismatched today over into the matched category. And in order to do this, we have been trying to reduce the number of specificities. Instead of 90 down to a smaller number that we will be matching, one by Craig with Duquesne and Rodi, and Dr. Takemoto in our laboratory has based the number of residues to match down to 17. So now he's trying to match only 17 factors. And this is Takemoto, and with 0 residues of mismatch, he's been able to pull these patients into the matched category here, as you see. But there's a little bit of a problem yet in the sense that he's also moved some of these failures into the 0 residue. And the way that we might be able to judge how big this impact was is to look here, where this is the conventional 0 ABDR, this is the 0 residue mismatch, which is similar to the 0 ABDR, but higher than the patients who have more than 0 DR. So the percentage increase here is not very large, but because it involves so many patients, we believe that the impact is significant. Another approach there we have worked on is to assume that certain mismatches are innocuous or are permissible. For example, HLA-1 mismatch is permissible to these recipients, but not to these. And this was based on studies of living donor transplants and then tested on cadaver donor transplants. With this maneuver, then, we were able to shift the mismatches over here into the 1 permissible mismatch category. And you can see that as the formula here that we have, based on the living donors, become better, we will be able to better predict what the permissible mismatch combinations are, since this is completely empiric. And here you see the 1 permissible mismatch does have a higher graft survival than the mismatch grafts. So in my last data slide, I would like to summarize the results of kidney transplant. Oh, I skipped one here. So what's happened here is that HLA identical sibling 0 ABDR mismatch is a very significant achievement of HLA matching. But for the future, we believe that the international pool is one of the ways, permissible mismatch, matching. Possibly something can be done with DNA, but you notice that it has no flower here. Finally, in my last data slide, I would like to summarize the results of kidney transplants over the past 30 years. Dr. Starzl is shown here since it was his spectacularly successful series of transplants, 1963-64, which caused the explosion of activity in this field. The 1-year graft survival rose from 40% to 82%, but the challenge of today is to think ahead for each patient where he will be 10 years from now. To think in such long-term views is difficult for physicians and surgeons, but for a patient, 10 years is a short time. HLA continues to be one of the most promising approaches to improve long-term survival. I owe much to many competent researchers who have contributed to the development of our laboratory. Dr. Chitrali Okaziwaki, you see, have worked for many years in the laboratory, and many Albert Chrysler colleagues have now developed their independent careers. And I should also mention that Sir Peter Morris should be listed here since he worked for 3 months in our laboratory. I'm indebted to members of our academic staff who has been with me for many years, as you see here. And they are a constant source of stimulation and joy for me. I would have difficulty continuing without them. The work I described could not have been done without the help of loyal workers such as these who have worked from 37 years down to 20 years at the UCLA Tissue Typing Laboratory. George Ayub and his experienced staff who had transferred from UCLA to the One Lambda company have also been with me for a long time. I'm greatly indebted to them for their dedicated work in providing tissue typing reagents worldwide. Lastly, I'd like to thank my wife, Chisako, for her patience and support. In my absence to pursue these quixotic adventures, she raised our family of 4 children, and now we have 3 grandchildren. Judging from his quotation, Sir Peter Medawar probably would be just as happy that our one son, named after him, has a Master's of Fine Arts degree and is the one who created these drawings. As Gerardo Pals mentioned, receiving the Medawar Prize from this society is for me the highest compliment I can ever hope for. It's been a wonderful 40 years swimming around with many friends in the ponds of transplantation and histocompatibility. I consider myself very fortunate to have participated with you in this common quest. From now on, it is on to La Mancha, where there are many more windmills to be conquered. Thank you very much.